Good.
Is my screen still sharing, Ashley?
It is, yes.
Okay.
Yep. Is this your beginning slide?
Yeah.
All right.
Yeah,
Well,
I just don't see that green fuzzy box around it anymore.
yeah. Good afternoon, everyone, and welcome. So we'll just give it a couple more seconds as everyone joins us today. Good afternoon to everyone who just joined us. We will get started very shortly. All right, let's get started. Well, hello, everyone, and welcome to our industry showcase session with Teladoc Health on April 25th. My name is Ashley Caesar. I am the Programs and Events Specialist here at Digital Health Canada. All right, so today's industry showcase is bringing high quality care to people in remote communities. And it is a great pleasure to introduce you all. We have Corey Fry. He's our AVP at Teladoc Health. And we also have Dr. Gregory Hansen. He is our pediatric intensivist at Jim Pattison Children's Hospital in Saskatchewan. All right, so we will have time for Q&A at the end of today's presentation. So please type your questions in the chat box at any time. All right, thank you all again for being here today. A warm welcome, and I'll now pass it over to you, Corey.
Awesome, thanks, Ashley. How's the sound coming in? We're all good?
Sounds great.
Yep. Awesome. Hey, good morning, everybody, and good afternoon. If you're on the other side of Canada, we're excited to be here. I've got one of our partners and clients and a great one of our great leaders in Canada in remote communities, Greg here, and he's going to be sharing a presentation. For those of you who haven't had a chance to learn a little bit about Teladoc, I thought I'd give you just an overview of where we are, what we're doing in Canada, the clients we're working with, and then pass it off to Greg. And our content is not going to run the full hour. We're going to run probably in the 20 to 25 minute range. And as Ashley mentioned, we'd appreciate some comments while we're going, and we can try and bring in some of your questions and some of your ideas into the presentation. And at the end, we've got just some questions on how your health systems might be supporting the work in Indigenous, rural, and remote Canada. And we can maybe have a bit of a dialogue. Greg's been, with his team, has been working in those communities for many years. And even if you have some questions about how you can possibly move the dial forward, he'd be happy to share some ideas on what's working, what's not working. So Teladoc Health, we are, one of the world leaders in virtual care. And, we say that not only because, we do a ton of virtual visits with a range of specialties, but we've been doing it for over 20 years. And so depending on the country and the market that our clients are working in, or where they live, or where our patients are seeking care, or where our hospital system partners are delivering that care, some of our services change. But what I can share is in Canada, we're really focusing on three main channels here. And the first one is Solo. So Solo is our virtual care platform, which really is a virtual care coordinator. So it really maps all of the manual in-person workflow that a patient might experience and a provider might experience, but digitally. So there's waiting rooms. You can customize intake based on the different clinical practice or the different services that your patients are going after. And this is also able to live within our clients' EHR or their EMR, like a Cerner or an Epic, and it's also living within Microsoft Teams. So Solo is really helping our clients to consolidate their virtual care toolkit and allow their team members to work out of their EMR or Microsoft Teams or standalone. The second area we're working in is our remote presence devices, and Greg will talk a little bit about that. This is really helping to further the reach and support specialists and clinical visits in remote and rural areas, as well as in major centers. And so these remote devices are putting the camera, the speaker, and that platform in the hands of the remote clinician. So you don't need somebody at the client side holding a device and and having someone say, hey, can you zoom in? Can you move it around? Sorry, that image is blurry, or battery's dead. These devices are built for a healthcare remote presence, and Greg will share a little bit about that. They're really, really effective in emergent use cases like telestroke, tele-NICU, and some of the other peds acute illness that Greg will share about today. The third stream that we're investing in Canada is really our medical group, and with our clinical capabilities, such as mental health, our navigating program, our counseling, and a number of digital apps that support clinical care across Canada. We're also able to provide extra clinical capacity to our hospital and health system clients when they need. When we were at HIMSS this past week in Boston, sorry, not Boston, it was Chicago. Not sure how many of you were able to go to HIMSS or if you heard about it. I'd say the number one feedback that we got from our clients, and I'd say one of the key differentiators between Teladoc and some of our other vendor, let's say colleagues, partners, competitors in the space, is our large clinical background. So when we are helping our clients with, say, virtual nursing, we've got over 150 years on that leadership team of nursing within a hospital and health system. And so when we're helping our clients to build these clinical workflows, we're not just doing it from a tech perspective. I'd say our partners are really saying that we are a clinical partner to the health system, and really taking a look at how they can not just look at consolidating IT and focusing on the CIO and CTO, but how we can really address patient outcomes, quality outcomes, and really helping to improve provider and patient experience. And at the same time, helping that virtual kit to be more user-friendly and really an enterprise strategy. So it's not just another add-on thing that came and doesn't really fit, and you need to kind of work around it. It can really sit within the enterprise, such as the EMR and Microsoft Teams, which is, where most organizations are investing today. You can see here solo fits all across clinical domains, right from home and community care, right into emergent use cases. Excited about virtual nursing and where that's going in the global markets, and we can chat about that another day, and then on to ongoing care at home. When I started working with Greg and his team and some of the people that I had a chance to meet, they said, Corey, this is really taking a step in the right direction in the calls to action. Health inequities are very much true today. They're not better. They're not getting better. In a way, they've been getting harder and more disparate. And so some of the work that we're doing, we're really excited. We're not experts, but we're learning alongside our partners as they bring us on this journey of bridging the gap between rural, remote, and Indigenous communities. And so this is something that we're still exploring, and how to bridge that. We're still finding people in Victoria, like a major center, without a GP. Think of how much more distance someone who lives in rural Canada feels when they also don't have a GP or even an emergency clinic that they can walk into. This is a conversation we'll have towards the end of our session. So I'm excited to introduce Greg. He's got a large team, but he's just one of them today, and they represent a few different organizations, but mostly we're working with University of Saskatchewan and Jim Pattison Children's Hospital, and I'm going to pass it off to him. So Greg, thanks for being here today, and thanks for what you're going to share.
Great, thanks, Corey, and good morning or good afternoon. It's 10:09 here in Saskatoon. We start with this slide because I think this slide demonstrates the beauty of Canada, as well as the challenges or the barriers that a country like ours has. And our story in Saskatchewan isn't unique. It's a story that's similar throughout North America and other developed countries like Australia. And basically, you can see Saskatchewan as a province. If it were a country on its own, by land area, it would be the 42nd largest country in the world, right behind Afghanistan. Afghanistan has a population of 40.1 million, and Saskatchewan's population is around 1.2 million. And when the Rough Riders are playing, it's significantly greater than that. The beauty of Saskatchewan is in these photos. It's endless roads. It is farm fields. It is great boreal forests in the north. But because of that, it's also a problem when we have isolated or remote communities that have children or adults. I'm a pediatric intensivist who will concentrate on kids. And how do we improve access of care to these patients? Next slide, please. When we look at where Saskatchewan kids live, this in many regards is an unfortunate reality, because 35 to 40% of children in Saskatchewan live in communities that are less than 1,000. And so not only is Saskatchewan incredibly vast, but many children, over a third of them, live in these communities. And so you pause and ask the question, there's two realities that are here. One is, how do we improve our presence in these communities medically? And number two, what are the solutions that are on the table? Now, the obvious one, and we read about this in the news, is trying to recruit practitioners into the rural areas. And recruitment to rural areas is difficult. And obviously, the smaller the community, the more difficult it is to recruit. And throughout Canada, America, Australia, governments have tried to do this with various success. The other option, obviously, is to do things digitally, to kind of think outside of the box and try to improve access, but not relying on a heavy recruitment that has failed throughout Canada. So next slide, please. So about 2013, 2014, we were faced with the reality that we had many, many sick children requiring a tertiary center like our hospital, that were in communities less than 1,000 and were 500, 600, 800 kilometers from our center. Now, we wear double hats. I'm a pediatric intensivist, but when I'm not in the PICU, I'm also the provincial transport doctor. And there's 5 of us that fulfill this role. So we provide 24/7 coverage for any critically ill child that presents in any healthcare system in the province. And so we see this firsthand, the inequities of access to care, the challenges or barrier, the smaller the community is. And we paused and we asked ourselves, how can we improve care? How can we improve access? And how can we make reliable diagnoses of this child that's critically ill so that we can provide them with the health resources that they need in the most timely manner? So we picked a community called Pelican Narrows, and Pelican Narrows population is less than 2,000. It's over 600 kilometers as the crow flies from Saskatoon north. And it's on this beautiful Pelican Lake. It's accessible by one road that's variable depending on the weather, depending on the season. And if a critically ill child presents in Pelican Narrows Health Center, you can imagine that it's very difficult to get there. So this was the first opportunity we had to engage in a community and, working with them, create a solution that would work for them. And what we decided to do is we worked with Teladoc and we deployed this robot, as you can see in the middle screen. And the robot's about the size of a small adult. It has a high fidelity screen that you can see there. And so the provider, the family, the patients can see me, and I can see them, what you can see on the screens to the right, with that critically ill child in respiratory distress on the top, and then IV access on the bottom. The beautiful thing about this robot also is that it has a stethoscope, so I'm able to listen to heart and lung and abdominal sounds when the medical provider places it on the patient. And it has one or two tricks that are very, very helpful when we're trying to assess how sick the child is. Now, the interesting thing with kids, as you can see on that screen on the top, is that some children that present very, very ill, if they get adequate, aggressive, and timely treatment, as sick as they presented, they can make a rapid turnaround. And so not all these patients need to be airlifted to a very large center 500, 600 kilometers away. But in saying that, if a child is critically ill, I'm able to provide a fairly rapid diagnosis and expedite air assets so that we can bring that child to us as quickly as possible. The screen below is really interesting as well. And it was one patient we had where they were struggling with IV access. And if there's any health providers that are in the audience, The smaller and sicker the child is, the more difficult it is to get IV access. And many of our life-sparing drugs are provided via the IV route. And so access is very important. And we are able to help coach the team that was in Pelican Narrows to start an IV in a child that was very difficult to provide access for. Next slide, please. So we published this paper, and it was really a landmark paper using robotic remote presence technology. And what we did is we compared Pelican Narrows with historical controls. And before we had the robot in Pelican, 100% of the children that were in respiratory distress, for example, would be removed from their community. And I use the word removed because they needed tertiary care, or at least we thought they did based on the phone conversation that we had. But what we didn't realize, and what we learned subsequently looking at interviews that we followed up on these patients, is many of the families were very concerned and scared to come to Saskatoon for two reasons. And one of them, unfortunately, is the historical narrative of colonialism and with the school system of the past. And the second one is that there is comfort and safety and support in the community. And what we were able to do with the robot is we were able to keep 40% of the children in the community, follow them up less than 24 hours later, and then if they needed it daily or weekly. And what we found is that these children not only were able to stay in the community, 40%, but they were also able to stay in the community and were safe. And the last thing is the medical providers felt more and more comfortable because they were seeing these patients in follow-up on day 1, day 2, day 7, and their capacity to deal with sicker kids also increased. Now, the other important finding is that every child with the historical controls that we would bring to Saskatoon would stay in our hospital for roughly 5 days. Now, most of these children don't need 5 days of hospital, but when they are air flighted from their community over 600 kilometers away, it is often quite difficult to bring them back because of air services to those communities. And sometimes those communities are inaccessible completely due to weather or other factors. Next slide, please. So before we got our CHR grant, and I'll talk about that a little bit later, this is a map of Saskatchewan, and Saskatoon is circled as blue. And you could see that Saskatoon has a population of about 350,000. It's by far the biggest center in the province. And you could see that it's probably in the lower 1/3. We targeted very early on northern communities with various devices, and they're circled in red. And again, we focused on remote communities where we had a lot of consults, a lot of sick kids presenting, but you could see that there are vast areas that did not have this amount of access. We obviously needed to improve that. Next slide, please. So based on the recognition that we had a landmark study demonstrating what we thought it would demonstrate, we thought that the best way to go forward was to increase virtual capacity throughout the province. And because most isolated and remote communities are Indigenous communities, we wanted to partner with them. And so we proposed a CHR grant in collaboration with the First Nations University of Canada, which is situated in Regina. We worked with the two other large institutions, the University of Regina and Saskatchewan, and we were awarded about 1.35 million to develop virtual capacity in Indigenous communities. Next slide, please. Now, this is a prospective observational cohort study, and working together with community, and it continues to be a wonderful collaboration that is ongoing. We really wanted to look at two aspects of delivering virtual care. And I'll go on the bottom part first. What we wanted to make certain is that we wanted to develop a network with Indigenous communities, with Indigenous health providers, to make certain that we are rolling out a virtual healthcare system that is compatible with Indigenous notions of well-being. And what I'm finding out more and more in medicine is that very often we have ways, we develop methods, treatments, algorithms that work from a Western medicine ideology, but sometimes that's inconsistent with Indigenous notions of well-being. And so as we're creating this network with these communities, we want to be very mindful that we're doing it in a manner that respects their notions of well-being. And so throughout the process, we are offering interviews as well as questionnaires so that elders, patients, their parents, and care providers can provide targeted feedback to ensure that this is consistent with their way of life. The second arm is going to be our quantitative data, very similar to the Pelican Narrows study. We want to look at what is the age of patients we're mostly looking at, how often do we have to transport, very, very similar to the study in Pelican that we will match with historical controls. New slide, please. So based on the funding that we have received, we just have purchased devices from Teladoc, and they have crossed customs, and they are currently being installed in the hospitals that you can see in purple. And so with this, with the purple and with our blue and our red, every major regional hospital in the province now has a virtual device. But the very interesting question then is, how do we access all the Indigenous communities? And so we have targeted with 2 intertribal councils, health councils, and through Corey and his team, I want to draw a big circle around the province, because rather than deploying devices, what we're doing is we're deploying tablets as well as using providers' own personal cell phones to provide a platform, as Corey talked about, solo, so that we can basically have a data encrypted, safe virtual visit in hopefully every Indigenous community that agrees to be a part of this study. So we're hoping that at the end of our 5-year study, that the whole province is going to have a big circle around it, and every Indigenous community is going to have prompt, reliable access to a virtual consult. New slide, please. So Corey?
Sure. Thanks, Greg. You know, I was going to go back to this one and just share a little bit about, you know, drawing that big circle. And I think we want, you know, we can't tell exactly where everyone's from. You know, on the list, we can see that there's a group of people that are participating, but we love to hear some feedback where, you know, I see one question coming, but if you have any questions or comments for Greg, you know, he's talking about this study that they will do, but they did already finish. You know, 3 to 5 years of work, you know, doing similar things. So this is not to be done. It has been done, and they're just changing a few of the pieces of their research and continuing on. And, you know, when we saw that picture of some of these robots that he was chatting about earlier, I just want to share that some of these early robots that Teladoc invented were self-driving. You know, the idea that you could drive a robot around when you had very, very limited staff in a remote clinic. The footprint of devices are traditionally pretty small. You know, we just did a road trip to rural ER, and, you know, these ERs were looking to bring in doctors like Greg, like a specialist that lives in a major center to help with telestroke and tele-NICU, and they were looking at devices in their ER. They're not always self-driving. Sometimes they can just be wheeled around. But I'm just gonna see, I've got a couple questions here, and you know what, they're hard questions because these are not easy things to tackle. And so we love to hear if there's anybody out there that is tackling these calls to action. You know, if I'm not an expert, like I said, on the Truth and Reconciliation Commission, I have not read it enough times to really be able to respond. But you know, one thing that that has happened in Saskatchewan, that's another one of in 18 to 24, is really improving the education for Indigenous communities and creating health workers within those populations. And it's another big vision of the Saskatchewan team, is to actually train and educate people in rural, remote, and Indigenous Canada to then support these same communities that Greg and Tanya are providing the specialist care to. So that's a really exciting part of the project. Was there anyone out there that'd be willing to respond in the chat message to how their health system might be supporting some of these wanted health outcomes, or any questions for Greg about his work? One of them came up is, how do you tackle connectivity challenges such as low signal and bad internet? You know, if you look at where those circles are, they are all around Saskatchewan, and they are in remote and rural Canada. And so far, we haven't had one clinic that we've put a device in that hasn't worked. You know, when Teladoc invented the devices, they focus on low bandwidth and this technology called bandwidth searching, you know, in Corey speak. And basically it looks for a signal, and it can provide that remote connection on fairly low bandwidth. And so far we haven't experienced a massive challenge with a remote community. And as Greg mentioned, like Pelican Narrows is pretty far out there, and maybe there's going to be days in a crazy snowstorm when it goes down, Greg, but I haven't heard that yet.
Yeah, and I'll comment to that as well. It's an excellent question, and one that we get very frequently. Saskatchewan, I think, has a little bit of an advantage in that our telecommunications largely is still public through SaskTel. So we have very good tower coverage throughout the province, probably better than most provinces. But even in saying that, Indigenous communities, their buildings tend to be centralized so that they'll have their health center, their community center, if they have a school, if they have a band or a council building, they tend to be grouped together. And because of the federal mandates and provincial programs, a lot of them have fairly reasonable boosters as well for bandwidth. And so many times these communities are quite large from an area perspective, and the extremes are poor, and they might not have cell coverage. Usually in that central compound, if for lack of better words, does have booster and does have good access. There's one center that I did visit, and in the center, because it's primarily where the council works, and as well as the health center, they did have reliable internet, they did have great bandwidth, but you went across the parking lot and that went away fairly quickly. So that is an ongoing challenge, but I would believe that most centers and communities do have adequate bandwidth to support this.
Thanks, Greg. You know, Mary, I'm going to try your question, and if I'm responding incorrectly, maybe you can just help. Actually, can you help me? Are people able to come off mute and ask their question, or is it just better to do it through the chat window, Ashley?
They will not be able to come off. It's only through chat.
Oh, okay. Sorry, everybody. You're going to have to bear with us if we read and interpret incorrectly. So, Mary, the question about interoperability, I can answer that in two ways. First off, the platform that Greg was talking about with Solo is very easy to push to a number of clinicians, regardless of where they work. And so, for example, the license for that is, you know, as a single user, is fairly easy to give to a number of people. And actually, someone was just saying they're not able to see the questions in the chat, so not sure if people can. Yeah, not sure how people can do that, but yeah. Ashley will come in and share how they can do that after. And so, Mary, we can give that access to, you know, for example, a specialist in Regina, then they can go and access the same devices that Greg is talking about and see through there. In regards to interoperability, Solo can actually, you know, push that message back to the EMR that physician is working in, or Allscripts like the EHR in SaskHealth. So in that way, it is interoperable. And I guess another way I could put that is, let's just say you didn't want to use a Teladoc device, or you didn't want to use Solo. In Greg's research, if there are tablets being given to those communities, then those tablets could be, you know, in a way multi-purpose. So then you don't necessarily have to be part of Greg's project, but if you're a specialist providing care to somebody in Pelican Narrows and you're not part of, let's say, the pediatric transport team, then yes, that specialist could invite a person in that clinic to use the tablet for the visit. Again, we think tablets do have some, they're not as efficient as a stand-up device, and as Greg was sharing, but they're still going to be a lot better than just a phone conversation. So hopefully, Mary, that answers your questions.
And I'll add to that as well. One of the slides I demonstrated that there was, I think, 5 northern centers that had devices in them. And so we started with our study in Pelican, it expanded to 5 centers. And now our respirologists, our cardiologists, and us, we continue to use them. And in fact, we had a very unfortunate shooting many, many years ago, where a pediatric patient spent a lot of time in the ICU, wanted to return to the community, but needed ongoing physiotherapy. And not us, but our physiotherapists were able to provide physiotherapy care via remote presence through this device. And so, yeah, once the network is established, anybody can use it. But this is also one of the secrets of providing the networks. If we went to our health authority, and the question I'm often asked is, how did you get this up and running? And said, we would like to put 8 robots in 8 centers, how about it? They would flat out say, absolutely not, because most health authorities have their own kind of digital approach. You don't want to step on toes. In our province, it was not the standard that we were looking at. And so we're able to develop it through research, create a very reliable platform, and then open it up to everybody else. So the 5 devices that are in the north are being used by any provider now that wants to use it. And our hope is that once we provide complete provincial coverage and it becomes a part of the fabric of developing healthcare, that everybody will hop on board as well. I see the other question is, will they remain at the end of 5 years? How far in the study are you? 6 months, 1 year? So good question with that. So our devices that we've had in Pelican Narrow, they came in 2015. It remains there 8 years later, as with all the other devices. The 4 lights that we purchased that are being put in regional health centers as we speak will be there as long as we possibly can keep them there. And so we do have a commitment with these centers. We will provide the maintenance and the upkeep costs during the duration of the study. And like we did at Pelican, we will continue to negotiate with the health authority that once the study is done, then they will accrue the cost of maintenance, et cetera, et cetera. As far as this study is concerned, we're 1.5 years into this study. It's a 5-year study, so we have 3.5 more years to go. And so one of the reasons for the delay, and it's not necessarily a delay, it's the beautiful thing about doing research with Indigenous communities, is I can have an idea, but it's an idea at the very best. In order for that idea to manifest into something that's meaningful, requires months and months of community engagement. And by the time the project is done, it's not my project as a researcher, it's the community's project, which is a beautiful thing. And so we plan to start data collecting at the end of May. And so we have essentially 3.5 years of data collection. And then after that, it's going to be ongoing.
Thanks, Greg. I'm going to merge a couple of the questions here together from Sam and Melissa. And then, Greg, if you can see Melissa's question, I think that would be a good one for you to handle. When regards to the role that larger government bodies play and where these devices are going to live, I'm just going to share a little advertisement for tomorrow. Digital Health Canada has webinar Wednesday, and Dr. Mendez, who is a well-known virtual leader in Saskatchewan, is going to be presenting. And if you haven't signed up for that, I encourage you to sign up. And he'll share a little bit about how other systems can play a role. But when Chris, you're asking about where these devices are going to be, there's a group of people in Saskatchewan that really see devices in rural communities being the way of the future, and it's currently like the way of the present. And rather than driving 400 kilometers or 500 kilometers to an ER, if you can connect with a specialist and make like a family-based decision, like with Dr. Hansen or some of his partners like Dr. Holden, make a decision that we can keep a child in community rather than sending 2 people like on a 300 or 400 kilometer journey. That's making a big difference, such a big difference that the government is already starting to make larger investments in supporting virtual care leaders like Greg and the partners that he's working with in expanding this program. And maybe Greg, you could handle the, how many providers are supporting the network and what kind of support from large departments is required. And you kind of alluded to it a little bit, sometimes large departments, and I think we can all agree to this, large departments can make large decisions, take a large amount of time. And that is one of the biggest challenges we faced, as Teladoc, is trying to share the vision of virtual care in a way that doesn't create like a mega project that requires hundreds of people to all shift what they're doing. Because if you try and ask 100 people to shift what they're doing, you're going to have 100 meetings. And we're really trying to help support enterprise strategy without it making such a major shift. Go ahead, Greg.
Yeah, so just to build on what Corey said, how many calls do you anticipate? So in Saskatchewan, we transport around 600 kids a year from remote, isolated, and rural communities to our tertiary center. Of those 600, about 80%, 70-80% come to our PICU. And for every call that we receive and transport a child, we receive about 5 other calls. And so we're looking at about 3,000 to 4,000 calls a year. And as I mentioned, because 35% of our kids reside in communities less than 1,000, of those 4,000 calls, probably of that, 1,500 calls are coming from smaller communities. As far as what is the role of larger governmental bodies, I wanted to address this a little bit as well. We have engaged with over 40 different Indigenous communities through 2 what they call intertribal councils. So health councils that have Indigenous leadership that represent smaller communities. And every single community that we've talked to, and every single medical provider, and every single elder that we've talked to almost tells the identical story. And that is that they feel their community is not really provincial and is not really federal. And they find themselves in this constant battle of when they're seeking funds. Is it federal? Is it provincial? And the provincial governments are very easy to say, no, it's federal. And the federal governments are very reticent to say, yeah, I don't know, maybe it's provincial. And so there's this ongoing battle between the two, and they get stuck in the middle. And so that's why we kind of worked with them directly rather than looking at provincial authorities and rather than working with federal authorities, and primarily from an academic perspective with one-on-one conversations. Now, Dr. Mendez, who will talk tomorrow, has done this for years, and he has approached federal bodies, and he will be creating something that's very large and very magnificent. But that's taken years and years and years of negotiations at the federal level. And so that's why we were able to be successful, because we were small. We worked directly with these communities. And because we didn't have to deal with the bureaucracies, we were able to provide meaningful change for the communities and work with them directly. And I think that's the only reason why it was able to go forward.
Thanks, Greg. Something else that's coming to mind, if you're on this call and you're part of a, whether it's a virtual care team or you're a clinician, or you're wondering what is a catalyst to really getting something like this set up, what I have found is that if there's an on-call team already available, like 24/7, that's a big catalyst to getting things going. When we look at some of our clients who've had a rapid adoption of a service that Greg is talking about through Teladoc and devices, if you have a breakage in service, then that remote community, if they call and there's nobody there, then that on-call network, once it's set up, I'll give you an example, like with telestroke, or as Greg is talking about, the PEDS transport team, like the ICU, they're on call. So even if Greg is got the on-call phone and might be, helping a friend move, or is, not in a hospital, that's the beauty of the device. So he can actually get a call on his on-call phone, get a direct link, and with one button, like one push, literally open up the visit on that device in Pelican Narrows. So he could be on call, but he doesn't necessarily need to be in a hospital. And it's the same thing with the telestroke units we're working with. If they have, let's say, 10 neurologists that are on a rotation on call, whenever that stroke presents to that ER, whether that's in rural or in a major center, that ER can just press an on-demand telestroke consult, and wherever that specialist is, they get it right to the device of their choice, whether it's a cell phone or a laptop, or right into the platform like on an app, and then they can provide that consult. And that's really like if you're looking at ways to improve care into rural, or even we call them spoke sites. You know, I'm from BC, and if those of you are in BC, you know, Vancouver to Hope is still like an hour and a half, depending on traffic, could be 2 hours. That's not, you know, in the middle of nowhere. That's on a major highway, but it's still a 2-hour drive for an intensivist if you're rounding. And so when we look at spoke sites, we even have clients looking at putting devices, you know, Greg's talking about the huge province of Saskatchewan. We see people putting devices even in major centers, because a drive across town is still 20 minutes or 30 minutes. And that emergent use case can be seen within seconds.
I see.
I'm just reading a question here.
Yeah,
Go ahead, Greg.
Yeah, what type of support is offered to the participating sites? Scheduling, way of consults, requests are sent to the on-call team, technical support. Yeah, so my area is critical care, and as Corey was talking about telestroke, I think that there's several different arms the way digital strategies can work. In the critical arm that I'm most comfortable with, because that's where I practice, we're really not making schedules. We're simply addressing the immediate needs of a patient, and telestroke is very similar. So in order to make that work, as Corey says, you need 24/7 physician coverage at the tertiary center, and there's always a stroke neurologist, there's always one of us. And as far as on that referring center, either a rural, remote, or isolated community, that patient is presenting to the health center. There is a provider there, be it a nurse practitioner, a physician. And so there is no scheduling there either. They present with a critical illness, and really they need to find access to the tertiary center physician that is on call. And so in Saskatchewan, it's the same with stroke, it's the same with us, is that there is a central number that's called, and we receive the phone call, we get the demographics, we get the story, and then we turn on the robot or the device, and we have that virtual encounter. Ideally, we would like that call to come through the teledoc devices so that we can bypass that central number, but we're not there yet. We're probably 10 years away from that. And so really, from what we're doing, scheduling is not required, and scheduling isn't required on the other end as well. And that's one of the reasons why I think you see digital health really excelling in the critical world, because of that immediate requirement of help, but also cost saving. So for example, if you have a patient, an adult who's stroking, or if you have a critically ill child, to put an airplane off the ground, pick up and fly back, at least in Saskatchewan, is $10,000 minimum. And as I mentioned, we did around 600 transports last year. And of those transports, probably 350 were with fixed wing, were with airplane. So you times that by $10,000 a minimum every flight, you're talking about an astronomical number. And for some of these devices, the fancy robot that we showed you that I could drive from my computer when we purchased it years ago, I think was $270,000. Seems like a lot of money, but if we're able to keep 40% of those patients in their health center, then it pays for it right away. As far as the technical support, and this is where this is a big reason why we work with Teledoc. The technical support is provided by Teledoc through a subscription or maintenance fees, but we also have our own team of 2 technicians that help as well. And so the technical support isn't onerous whatsoever. And when you look at many of the e-communities that are established by healthcare systems, they often have staffs of 40, 50. They're massive bureaucracies. where we've been able to be very lean, support now over 10 devices in the province with really a team of 2 and help with teledoc. And so the technical support is really quite minimal.
I can add one thing to that. The technical support number is right on the screen, and because of our prevalence in emergent use cases, our devices are typically the ones that stand, and the ones that we're discussing here are rarely sold without a support contract. We find time and again that if a clinician turns to another device like one of ours, for example, or like an iPad on a stick or another screen on a rollie, and if the battery's out or if it's just not connected to the internet, they're not going to turn to it again in another emergent use case. And we've seen that time and again where technologies are put in closets because they're simply not used. And so because of the partnership we play, especially in things like peds ICU and telestroke and cardiac, we can't have our devices going down. And so the support contract has 5 nines availability, and we ping our devices every 2 minutes across the globe, the thousands that are out there, and we will tell Greg's clinic that it's down before they will ever know, or that it needs to be plugged in, or that it's not connected to the internet. That's part of our support team. And so that's just one of the ways that you can support emergent use cases in rural Canada, is by not having to hope that somebody plugged in the iPad or hope that it's connected to the internet. The goal is to be always on. And Greg did share a number back in 2015, something that was pretty special back then, but the cost of devices has got considerably lower as technologies have improved, scale, and so if your system is looking at that, we're happy to share how it can be purchased and stuff like that. So Lauren, what apps do you use? Go ahead. Do you want me to do that one?
I'll tell a little funny personal story. So what apps do you use or need to be installed on provider devices in order to connect to the remote teledoc unit for remote PICU and ICU support? So I can talk from our end. So on my phone, I have an app that I download, and from that app, I can access all of our robots, as well as a number of test robots that I think are in Santa Monica Boulevard, where I can practice my driving. They have a mock-up hospital ward there, so I can practice my driving. I can practice on focusing the camera, et cetera, et cetera. But I'll let Corey talk about the other end. But as he was mentioning, when I'm on call for transport, I don't need to be in the hospital. And last summer, I should show you a photo. I got a consult, and I was at my parents' cabin water skiing with my kids on the boat. And I'm in the middle of the lake in Alberta. I get this critical call from Pelican. Actually, one of our nurse practitioners was up there. And through my phone, accessing the app, I was able to see my patient or a patient and the family via my cell phone. So from my end, it's very, very easy. And I'll let Corey talk about the other end.
Sure, no, that's great. We use an app, and it can also be browser-based. And so when somebody, typically like an on-call network like Greg and his team, they're ready to go, and they know how they want to access those devices because it's pre-set up. But if your patient is doing like a BYOD, or Greg has to call in another specialist, so there's an ability for 2 specialists, multiple specialists to look through a device at the same time, that can all be browser-based. So if you were to send someone an on-demand meeting from a device or from Solo, they can just open it up in the browser of their choice. And that is typically seen as the quickest route to connecting with the patient and the provider. And if is anybody interested in seeing those connections, please just ping me. My information will be made available, and I'd be happy to provide a demo or have someone on our team provide a demo of the different ways that clinicians are connecting.
All right. So I think that is it with questions, and we do have a couple of more minutes. So if anyone has any last minute questions, feel free to put it in the chat. All right, and as Corey mentioned, if you want to reach out to Corey or Dr. Hansen directly, feel free to reach out to them directly, or you can send an email to webinars@digitalhealthcanada.com and we can connect you that way as well. All right, so we will give it just a few more seconds before we end it, but I would just like to let you know of our upcoming conference. It's our eHealth conference where you can meet a lot of exhibitors there as well, from May 28th to 30th at the Beanfield Center here in Toronto. So if you need further information, feel free to go into the eHealth conference website. You'll find lots of information about the conference as well as registration. Okay, so I will end it here. If anyone has any further questions, feel free again to email webinars at digitalhealthcanada.com, or you can reach out to Corey or Dr. Hansen directly. I will just put a quick link in the chat box for everyone. If you can just take just a few seconds of your day just to fill out a very quick survey, that will be great. And if anyone else has any further questions, again, email one of us, Corey, Dr. Hansen, or at webinars@digitalhealthcanada.com. All right, so is any
Thanks, Ashley, that'd be great.
Corey?
And for those of you, if you can't make it to eHealth in Toronto, but you have colleagues that are going, Greg and some members of his team will be there. We'll be there. And if you'd like to sign up for like a newsletter sharing like where our clients will be and where some of the events we do all across Canada, please let me know and I'd be happy to add that to you and kind of find out where clients will be sharing these stories, and we'll go from there. Greg, thanks so much for sharing about your research today and your experience. And Ashley, thanks for hosting.
Yes, thank you. Yeah, so we're going to be sending out an email to all the attendees to eHealth for the event app by May 1st. And then you can also visit the Teladoc Health profile and Corey directly there as well, if you want to reach out to him directly before the conference. All right, so
Thanks,
we'll end it here. Thank you very much, everyone, and we'll see you next time. Have a great afternoon.